And I will also take attendance of the people that are here now. Thank you for being here and being on time. Excellent. And I have the chat pulled up, so if you're going to talk in the chat, I should be able to see it as well. All right, so today's topic, as you all know, is about behavioral health tips for patients living with diabetes. So this is obviously something that's extremely relevant for our patient population. Probably one of the most common. Hi, Dr. Watson. Oh, someone's knocking on my door. Let me make sure they're able to join. The same link, it's on the email from Monday. Same link. Dr. Kumar will be joining us as well. Hello, Dr. Watson. And people having trouble joining, remind them it's the same link that I sent out via email on Monday or on the calendar, same link every time. All right, I'm going to dive right in. So some things we're going to talk about today, as much as we can within the time that we have, are common struggles and barriers for people with diabetes, especially when it comes to self-management, how distress and burnout are associated with diabetes, and how it comes along with that diagnosis, how all of these things impact adherence, different assessment and interventions that can help with our patient population when we're trying to understand these relationships, and how warm handoffs can fit into this patient population as well. Sorry about that. All right, so challenges. I think a lot of these are not going to come as huge surprises to people. The challenges that this patient population faces, even obtaining care in the first place, understanding the diagnosis. It can be a difficult diagnosis for people to understand, and there's a lot of miseducation, wrong beliefs, even for people who have had this diagnosis for a long time. People get confused about how exactly it works, what it means to have diabetes. Self-management is one of the biggest concerns that people have in terms of their ability to manage their diabetes by themselves, because we can't do it all for them, right? So the patients need to be able to hold up their end. And that isn't easy for a lot of reasons. And especially for patients who are struggling with other disabilities, other psychosocial stressors, that's going to make it even harder. And all of these things contribute to those feelings of hopelessness and helplessness that patients with diabetes often experience when it comes to managing their diabetes, is that it feels like too much, which can contribute to even worse adherence. And it can be scary too. It's scary to have those complications. It's scary to feel like you don't have control over your own body. And sometimes people just avoid the doctor or thinking about this diagnosis altogether because of all this. There's not much we can do about that, but we can understand that that's what's going on for some of those patients. And that's why, to fully make sure that we are supporting our patients with diabetes, we need to understand they're existing within a whole network. And to successfully manage diabetes, we need to make sure that it's not just the patient that's involved, but everyone in their social support network is relevant as well. So that includes not only us, their medical team, but also mental health professionals can be part of that medical team. The community, family, friends, a pharmacist is one that's not on here, but really should be, because that plays a huge role, your pharmacy and your pharmacist, in managing this diagnosis effectively. And there are even people who are the diabetes educators, like we have here at Neon, that help patients understand truly their diagnosis in order to manage it more effectively. So rarely is one professional or one appointment, one intervention enough to effectively manage, right? We need this whole team of people. We don't want to only educate patients, we also want to educate the people in their lives as well. So another way of thinking about how complicated this is, when we think about the diabetes outcomes that we're most concerned about here at the bottom, obviously we think about the care that goes into that. So are people coming in for visits? Are they monitoring their glucose? Are they using their medications like they're supposed to? Are they using the technology that they're provided with as they're supposed to, managing their diet? And that's typically where we tend to focus. But really, it goes out a lot bigger than that. The relationships that we have, genetic factors, age, the neighborhoods that we live in, our education, our social community context, all the policies surrounding insulin, or policies surrounding healthcare access, or policies surrounding education. And if you're worried about housing or violence in your community, where is diabetes going to fall on your priority list, right? Probably not as high. So like all the things we talk about with social determinants of health, as medical providers, the treatment team really focuses in at the bottom of this chart. And that makes sense. That's your role. But it doesn't mean patients aren't impacted by all the things in this chart. And sometimes we need to actually think about those bigger pieces and address those in order to address the outcomes that we're most concerned about. Some examples of that, for example, is we know that racism, here I'm going to go back to that same racism and other social determinants of health that we often talk about impact the different prevalence of diabetes across different racial groups. And we know that it's not evenly distributed across race or across education. Black men and women are at higher risk of both developing diabetes and dying from it, as are people with less education across both Black and white populations. And what's interesting about this is that a lot of people want to simplify it to just access to care. But studies show that it's more complicated than that. This isn't just about having less access to care. It's about living in food deserts. It's about not accessing the benefits that might be available to you and having less support to access the support that might be available to you. One study found that Black and Hispanic Medicaid and Medicare participants had less coverage and awareness of the coverage for their diabetic testing supplies and self-management education. One second. So it's not just about access, it's about understanding what that access means. So let's get into some of the mental health specifics of how this is going to impact patients as well. So unsurprisingly, we already know that depression is associated with smoking, lack of exercise, unhealthy eating, and it's a risk factor for developing diabetes. But beyond that, having depression and diabetes can make it more difficult to want to exercise, more difficult to eat the way that you are supposed to eat. And therefore, depression really impacts non-adherence and is a significant predictor of difficulties with adherence and self-management. So that's kind of a rule out that should always be in the back of your head when you have a patient who is struggling to manage their diabetes. Is depression the factor here? Same thing for anxiety. So patients might have anxiety about fear of complications, anxiety completely unrelated to their diabetes, about psychosocial stressors. And the thing about anxiety is that anxiety leads to avoidance. People avoid the things that make them anxious. So if dealing with your health makes you anxious, you just avoid dealing with your health, makes you feel better short term. Long term, it causes lots of problems. But anxiety can cause delays in care, lack of engagement in care that contributes to those long-term negative outcomes as well. But finally, when we're talking about diabetes, both risk factors for developing as well as managing diabetes long-term, we talk a lot about food, right? We talk a lot about eating, and we talk a lot about weight. And this could actually increase the risk of bulimia and anorexia for people with type 1 diabetes in particular, because there's so much emphasis on food and controlling food that people can develop a disordered relationship with food. So it's a risk factor for people with type 1 specifically. And in terms of type 2 diabetes, people who engage in binge eating, which is another disordered relationship with food that often goes along with restriction. So patients who don't eat food for a period of time, restrict themselves, then eat a lot in a binge, that unhealthy eating pattern, which oftentimes people are rewarded for because they are told they're doing a good job at dieting and things like that, can actually lead to having more problems with managing blood sugar. And there's even some evidence of people who almost use their insulin as a way to punish themselves when they're feeling upset about their weight or their body, and they might withhold insulin in order to lose weight. And that can be a way of also having some disordered eating patterns that interact with diabetes. Because generally, the more we focus and obsess about food and weight, and tell people that they're good or bad for how they're handling their food or the weight, which happens a lot when we're talking about diabetes, just naturally, the more people are likely to develop an unhealthy relationship with food and weight. That makes it even more difficult for them to manage, even if we have the best intentions. So distress and burnout. These are terms we're obviously already familiar with, right? But there's a way that they specifically manifest in patients with diabetes. And I like my little picture at the bottom that I found that says, I can't diabetes today, don't make me diabetes today. It can be exhausting to have to manage your health like this. And this is often talked about with type 1, but it's also relevant for type 2. And the distress part is highest at diagnosis. So difficulty accepting the diabetes, the fact that this is something you're going to have to manage and address. There's a lot of blame and shame that goes along with this diagnosis for people. And it's extremely overwhelming. You get hit with all this information. You need to do this, you need to do this, you need to do this, you need to do that. Or else this terrible thing's going to happen to you. And you may or may not have the support that you need. And all of that can lead to a higher level of distress. And eventually, if that distress remains high, it turns into something that they call diabetes burnout, where people really start to feel angry and frustrated about it. Like, I don't want to have to deal with this anymore. I don't want to talk about it. I don't want to think about it. I don't want people to bring it up. I don't want to go to my appointments anymore. I'm wasting all my time going to these appointments. It doesn't even do anything. I'm having to check my sugar. Nothing helps. I'm tired of working this hard, not seeing any results, and always feeling down on myself and feeling really, really isolated. And they estimate that about 1 in 4 people with type 1 diabetes have high levels of distress, and 1 in 5 people with type 2 diabetes have high levels of distress, at least one, and burnout at least at one point during their journey with this diagnosis. And both of these things, if you're keeping them for a long period of time, can turn into clinical depression. That again is going to make it even harder to manage your chronic illness. So it can be helpful just to validate patients that this is a difficult thing and to name for them what they might be experiencing. Like, hey, some people have burnout with this. Is that something that's going on for you? And then talk about some other interventions that can be helpful with this too later on. So how can we help patients manage distress and burnout? It's not that different from managing any other type of emotional distress and burnout. Social support, that's huge. Can we ask for help from your healthcare team? Ask for help from caregivers. Let people take care of you, because it does take a team. It does take a team of people to help manage diabetes. It shouldn't just all be on you. And talking to other people with this experience, a support group or members of your family who also have this diagnosis, that can really help alleviate the distress too, just to talk to someone else who gets it. And sometimes you need to change the perspective. So one of the quotes that comes up a lot on diabetes support pages and things like that is, don't let perfect be the enemy of good. So sometimes people become really obsessed about getting the right blood sugar or the exact right diet. And if they're not perfect, they give up. And if they're not perfect, they're so mad at themselves. And having to be realistic about our goals and expectations, we don't expect blood sugar to be perfect all the time in that perfect range. And it's going to fluctuate, and we don't expect your diet to be perfect all the time. You have to allow yourself to be able to have some flexibility, or else you will get burnout. And it can also help to work on one goal at a time, which I think is really hard for us because we have a lot of goals for patients. Right? We want them to exercise, eat better, check their blood sugar more frequently. That's a lot of things. So why don't we just try to pick one thing at a time, something that feels realistic, and then patients can feel a little bit less of that burnout and focus on the successes. What has gone well? What progress has been made? What negative outcomes have been avoided so far? If someone's coming in for an appointment with you, that is a success. They are doing something to address this chronic illness, and we want to reinforce that because they could just be avoiding it altogether, right? So focusing on successes can help with burnout and distress as well. And finally, we want patients to pay attention to their feelings and realize that it's normal to be kind and compassionate with themselves when they're feeling this distress and burnout, and to recognize the power of self-talk. So if patients are talking negatively to themselves about this diagnosis and not with compassion, they're going to feel even more down, because negative self-talk always makes us feel more down. And like anything else, if you can reduce other stress in your life, you're probably going to be able to manage your diabetes better, right? So sometimes you need to look elsewhere, pick some other things, make sure that you're removing some stresses, taking some things off your plate, and then you'll be able to focus on your health more. All of this is easier said than done, as we know, but I think it can be helpful to remind us and to remind patients that there are things you can do and things you really need to do when you start feeling really overwhelmed. Otherwise, it's just going to get worse. For some reason, my slides are not progressing very quickly today. All right, so one time when behavioral health support can be really critical with a diabetes diagnosis is right away. When you get that news right at the beginning, people tend to have a strong emotional reaction or feel really numb and aren't really processing any of those emotions initially. And you kind of see everything, right? You see people being sad, being angry, disbelief, denial, that can't be right, I feel fine. No, like my uncle has diabetes and it looks like this, I don't have that. Confusion, I thought that I was doing really well. What does this mean for me? And shame is not on here, but I think it really should be. People feel ashamed because we have a lot of shame in our culture surrounding, especially type 2 diabetes, where we really focus on blaming people for that illness instead of having compassion for people with that diagnosis. So whenever patients you're giving, if you're the person who's giving this diagnosis for the first time, give patients a chance to have their feelings, to react, give them some space to have those emotions, and they're all valid emotions. And that's a really great time to get behavioral health involved right from the start. So even if they're just meeting once to talk about adjusting to having a chronic illness, it's really important because this is the time, initial diagnosis and follow-up is the time when adherence is often typically the worst. As people are new to the diagnosis, really struggling to figure out what they're supposed to do. So it's a really critical time for us to bring in the whole team, get everybody involved. We think about it later when people have been non-adherent for years or people are depressed, but really early intervention can make a big difference. Many words on this slide, but I'll help summarize it all for you. There's a lot of really interesting research on diabetes and adherence. And a lot of the things I spoke about in my training about adherence that I did a couple months ago applies here too, but I'm going to keep it more specific to diabetes in this case. So depending on how you define adherence, but you can define it in a lot of different ways, right? Adherence to glucose monitoring, adherence to appointments, adherence to medication regimen. About 30 to 75 patients are considered adherent, depending on how you define it. So it's a huge range, right? So who tends to be adherent? Looking at demographics alone, adherence tends to be higher with older, male sex, higher education, and higher income. Use of mail order versus retail pharmacies. So when people are getting their prescriptions via mail, they're more likely to be adherent than if they have to go pick them up. I think that's pretty obvious why. Adherence is more associated with people who are going to primary care versus specialist providers. So that's some good news for us, right? That primary care can provide some unique management that specialists aren't providing that helps with adherence. And when there's a lower out-of-pocket cost, shocking, right? So when there's a lower out-of-pocket cost for your medications and for your treatment, you're more likely to be adherent. There's a really, really sad statistic about how for every additional $15 a month for out-of-pocket costs associated with diabetes, adherence goes down by about 20%. So every time something is a little bit more expensive, people are significantly less likely to be able to follow those recommendations. So what about poor medication adherence? Where do we see that? New diagnosis, like I just mentioned. People who are worried about side effects, who don't really trust medication, they're less likely to use it, right? That makes sense. We want to make sure we're addressing those ideas and beliefs right from the start. People who are nervy about, what is this medication going to do to me? What are you putting in my body? What are these side effects on the labels? They're less likely to be using it the way that they're supposed to. People who feel like this is impossible. A lot of people come from families who have a lot of diabetes that aren't well managed. There's the genetic component to that. And so they might feel like this is something I can't do. It's not possible. My body's going to do what it's going to do, and I can't control it. That belief is really harmful. So that's called low self-efficacy. When patients don't believe they can manage their diabetes effectively, they definitely aren't going to. So we want to help them understand what they can do and what is possible. There's also really interesting research about patients who believe diabetes is a chronic disease, or patients who believe this is kind of like a temporary problem with their blood sugar. So if you believe that you only have diabetes when your blood sugar is high, and that's actually a pretty common belief among patients with diabetes, that when my blood sugar is high, I have diabetes, but when it's fine, I'm fine. I don't have diabetes anymore. Those patients are much less likely to be adherent because they're thinking that, hey, I only have a problem when I can see this really high number. The rest of the time, I don't. So that's the type of belief we really need to be proactive about addressing with our patients, and them understanding that regardless of what your individual numbers might say, this is something you need to address and follow the regimen until we come up with a different regimen. So if we change that based on your progress, that's a different story. But that we're recommending this for a reason, and that's because this is an ongoing problem, not just a one reading problem. And there's some interesting racial differences in beliefs about chronic illness when it comes to this diagnosis. And compared to white patients, Black patients report more concern about harm from all medications, not just diabetes medications. They report more concern that they're being overprescribed things, that physicians are just throwing prescriptions at them. It tends to minimize the threat from diabetes complications more. And that might be kind of a side effect of, as we talked about, if there's more of this diagnosis within the Black community, they have more examples of, well, my aunt has this and she's fine. They should also have more examples of complications, but our brains don't always work that way, right? Sometimes our brains want to jump to that belief that everything's going to be okay. And they also tend to have more health fatalism. Again, this idea that there's nothing you can do to prevent illness or death. It doesn't matter what I'm going to do. It's in God's hands. What happens, happens. And that fatalistic belief about your health can be a big problem. It's a self-fulfilling prophecy. You're not trying to manage your medication and your illness, and therefore it kind of turns into exactly what you expected, that you get the outcome no matter what. So it's helpful to understand our patients' beliefs, how they think about their illness, because if we understand that, we can understand what's going on with them in terms of their illness. All right. And this gets back to my big point when I made my other adherence presentation a few months ago, is that none of us are adherent. Okay, none of us are adherent to all the recommendations that your doctor ever gave you. You say you are, I don't believe you. None of us follow every CDC recommendation, every primary care recommendation we've ever been given. We all pick and choose what healthy habits we decide we can do and which ones we're going to ignore. People with diabetes are exactly the same. Very few of them are going to change absolutely everything, just like very few of us can do that. We need to be empathic about that and realistic about that when we're working with patients and deciding what they want to focus on. And one way to do this is the SMART goals worksheets that I've sent out by email before. I'll include in this email again. That's a really helpful way to prioritize and focus on just one goal instead of trying to fix 10 behavior goals at once, right? All right, so when you are dealing with a patient with diabetes here at Neon, what sorts of things should you be assessing that you might not already be assessing? So if you're already doing this, awesome, but if not, this might give you some ideas for other areas to focus on. We want to understand what patients already know about their diagnosis. And the best way to do that is to ask them open-ended questions about that and then see what they tell you. So tell me about your medication regimen. Tell me about your diagnosis. Tell me how things have been going. Their answers will be really, really opening your eyes to how they see it. Whereas if you jump right in with, I see your A1C is X, Y, and Z. So this is what I'm concerned about, and this is what I think you need to do, you're going to miss an opportunity to learn about how they perceive things. Do they think things are going well? Do they think things are not going well? Do they not really care? Are they really anxious or worried? You're going to find that out if you ask a few open-ended questions, ask them about their goals, and it's going to give you a sense of how well they understand the diagnosis. Do they understand what A1C means? Do they understand what an appropriate blood sugar goal is? So if you start by letting them tell you what they know, you're going to learn a lot more than if you just jump right in and tell them what you know already. So this is from a really great study that came up with some very specific interventions. I loved it so much, I just copied and pasted it right here into the presentation about both problem-focused and emotion-focused interventions for diabetes self-management. So when people are struggling with problem solving, you can use these problem-focused interventions. When people are struggling with emotions, the distress and burnout, you can use these emotion-focused interventions. And they have these concrete suggestions for the wording you can use right on the right here. Some great motivational interviewing strategies that we've talked about before. We want to make sure we're keeping an eye out for depression. We want to make sure we're involving other treatment members. But you won't know if you don't keep an eye out and if you don't ask these questions. So these are questions beyond just about diet, right? These are questions about goals. What's the hardest thing for them? What's getting in the way? How are they rewarding themselves when they do well? Because again, we want to help people focus on their successes. Are they avoiding all of it? These questions are going to help you identify some of those problems and barriers and emotions that might be at play that you didn't even realize were there. So it's a nice little chart that I'll copy and paste this chart into the general email so that you have it as an easy reference. You don't have to look back at the slide. All right. So other interventions that we might want to consider are educational interventions, because a lot of the research shows that people don't understand their own diagnosis and how it works and the awareness of complications, et cetera. So when I think about education for diabetes, I think a lot of people think about the first appointment. It's got to be ongoing. It can't just be the first appointment. It has to be every appointment. We can't assume anything. We can't assume that our patients understand something when they might not. A big part of that education is emphasizing the chronic illness and ongoing treatment part. This is not just a one-time only thing. Written materials can help people understand. So even if they aren't able to process it in the appointment, they can take a handout home with them. I have a great handout resource that I'll send you as well. And education for family and caregivers too. So the more people around the patient who we can educate, the more educated the patient will be as well. We want to focus on complications because complications are motivating in terms of adherence. We don't want to do it in a fear-mongering way where we're trying to scare people, but we want to explain that this is why we care, right? This is why we care about these things. This is why I'm talking to you about these things, because we want to avoid these complications. We want to talk about awareness of signs of emergency. A shocking number of people with diabetes are not able to identify the signs of a diabetic emergency, which can be really, really tragic and dangerous. And when we talk about education, you can also include education about this emotional stuff that we talked about, right? You can educate about distress and burnout and think about how validating that will be for patients. And finally, there's a lot of evidence that more frequent follow-up is one of the best ways to address poor adherence. So if we have poor adherence to patients, then we're not seeing them again for months and months and months. And I know a lot of times that's not outside of our control. But as much as we can create an environment of close follow-up, providing support for that follow-up, provider ride, getting friends and family to the appointment. Behavioral health is really great at providing support for follow-up. The more that we can provide patients with the type of education that they need. All right. So real quick, I want to talk about how integrated into this. So this is kind of a pyramid of the different ways that behavioral health can be involved in primary care. And my goal is to make NEON more integrated. I think you've all noticed that. So 5 here is kind of the least integrated. That's like we just refer to mental health, usually not even in the same building, and you just go there. 4 is like sharing the medical record, reading each other's notes, having a shared treatment plan. Our goal is to be moving towards 4, 3, and 2, especially with 3 and 2, that I and other behavioral health providers at the sites that we are available at are able to provide real-time support for your patients. They don't have to wait to see us. They can see us same day or very soon after. We can schedule an appointment right away. And also that you all are better equipped to provide some behavioral health interventions yourself. So those are the 2 goals that we're trying to work towards. And obviously, to do that, you need to know about your behavioral health providers at your site. So if you're at East Cleveland and Superior, you have Amber and Brittany. And if you're at Southeast, you have me, and Miles Broadway has Dr. Staniff. And you also, if you are at one of those places that does not have a behavioral health support person, you can also do consults over the phone. Dr. Staniff and I in particular try to be more available for those at our extensions 1178 and 1531. But we are here to help you with patients who are not maybe what you typically think of. So including these non-adherent diabetes patients, we could definitely provide some assistance. And I wanted to have Dr. Carter talk a little bit about how she does that. I'm not sure if she's able to join us. I'll just have to talk for her. She's not here. It doesn't look like she's. More of you have joined, so I'm going to take a second to take a picture for accurate attendance. The person who is on the phone, I do not know who you are, who's calling from a Huff number. So if you want to make sure you get credit for attending, make sure you email me or message me. All right. So when I was at Huff, before we all had to move, those of us that were at Huff, I was right across the hallway from Dr. Carter, and Dr. Carter did a wonderful job. I can sing her praises as she's not here, providing me with about 3 to 4 warm handoffs every single day for her adult patient load. And one of the ways that we did that, she and I worked on that together, is we did a couple of things that I think were really helpful. One, Dr. Carter would introduce the role of behavioral health. She would talk about me as a colleague, as a member of the team, and she would explain why she wanted me to be involved. That she wanted me to talk about how to take care of your diabetes better, for this example. And then she would check in with me to see if I was available then. Another thing we shifted to that I think helped a lot is we started to treat talking to me like lab work. Your patients aren't required to do lab work, right? But it's expected. We expect them to do the lab work before they leave in order to get the best care possible. So when you start to treat talking to behavioral health like that, a lot more patients start doing it. So instead of like, if you have a chance, if you would like to, Dr. Alto is available, you say, I'd like you to talk to Dr. Alto on your way out. She's right there. If you want to wait in the waiting room, she'll come get you. Now, they aren't required to talk to me. If people don't want to, they can certainly leave. But it's really interesting that if you kind of shift the expectation to being, this is an important part of your treatment, a lot more people will follow up, instead of treated as something totally optional and totally extra. Whereas people are like, no, that's fine. I'll maybe call them later. And then when you can, do the walkover and the introduction to your behavioral health provider. You can say, oh, her office is right here. This is X, Y, and Z. This is Amber. I hope you enjoy talking with her today. I think she's really great and you guys are going to get along. Makes it a little bit more personal, right? Nursing staff support can be so helpful with these logistics because sometimes patients are running to lab or they're in different rooms or you don't know where the behavioral health provider is or our doors are shut. Nursing can be a wonderful way to help us coordinate because you can say, hey, I want this person to see behavioral health before they go. Can you walk them over when I'm done? Or after you schedule them, whatever it is. That helps a ton. Otherwise, a lot of people fall through the cracks. And another part is that a lot of our patients are reluctant to talk to behavioral health or do therapy because of the stigma. So you want to get ahead of that by saying, like, I recommend that a lot of my patients do this. Like, this is important for everyone, which can really help at saying, like, this is not for you because you're crazy. This is for everybody because these people are really good at helping with this specific issue that you're dealing with. So I just wanted to give some examples of how Dr. Carter and I had built this up successfully at Huff, and hopefully we'll be able to implement it at our other centers as well, because all of our behavioral health providers are doing warm handoffs right now. And we're working to build doing that more and more and more so that we can move along that triangle. All right, I know we're running out of time, so these resources I will also put in the email. There is this great website that has low literacy diabetes handouts. So it's diabetes education that's written at like I think it's like a third grade or below reading level that talks about common concepts that people should know. We have our diabetes support group here at Neon that we can refer patients to. And there's a Medicaid program with a chronic disease self-management program we can refer to as well. And for kind of self-help, patients can go to these discussion boards that the American Diabetes Association has, and they can post and get support. And those are cool ways to get involved as well. So these are just different resources I want you to be aware of. And thank you all for being here with me today. As always, I'll stick around for a little bit for questions, comments, any sort of feedback or thoughts. I know that so many of you see these patients and care about these patients and want them to do better. And I know it can be so frustrating to see these outcomes that we see in this population. So I look forward to hearing anyone's thoughts. And we'll go ahead and stop the recording.